I thank to be here in this celebration of Wilson disease, but also celebration of the work that has been done here in Poland by Anna about the Wilson. And we move a century, so 100 years to a new Wilson disease. This was the report and the editorial that has been done to our work on movement disorders, describing a new form of a new model of Wilson disease that is not related to copper but related to manganese. This was a very interesting adventure on the neurometabolic disease because you know that manganese is toxic to the brain and usually is something that is not genetically reported and manganese neurotoxicity has been attributed to changes in dopaminergic, glutaminergic, and GABAergic transmission. Manganese is crucial in mitochondrial function and in oxidative stress and also in neuroinflammation. So basal ganglia are very much involved and are sensitive to manganese intoxication. And in fact, manganese intoxication is related to these abnormalities on MRI with storage of metal that look like different metal and are mainly present deposits in basal ganglia and also in mesencephalum. But in the literature, there are some very few cases of genetic syndrome related to hypermanganesemia. This was the first report of the literature in which in children it was described paraparesis, hypermanganesemia, and polycythemia. So from a clinical point of view, it was a liver disease with cirrhosis, paraparesis, hypermanganesemia, and polycythemia with basal ganglia involvement. After a few years, it appeared another family with dystonia, hepatic cirrhosis, and polycythemia, with increase of manganese level that has been reported in on journal Inherited Metabolic Disease. And after 3 years, in 2011, also a new child with iron deficiency and polycythemia, but it was also present manganese. So it was characterized, this new condition, mainly present in child, with hepatomegaly, with variable hepatic fibrosis until cirrhosis, movement disorders, mainly dystonia, polycythemia with hemoglobin concentration that are very elevated, and very marked increase of manganese. Our history, I am mainly adult neurologist, started with these two brothers that have been sent to us for an atypical Parkinsonian syndrome that did not respond to levodopa therapy. Were two brothers around 60 years with Parkinsonism, with polycythemia, with hepatomegaly, and liver enlargement with steatosis, and you can see here why it's not working. I don't know. So It was a classical Parkinsonian syndrome. Polycythemia was present, normal slight increase of ceruloplasmin, transferrin slight increase and decrease of ferritin, a sensory motor polyneuropathy, steatosis, and a specific muscle involvement. But what Parazar, we had a very large metal investigation. We have seen a very severe increase of manganese into the blood, and from in the brain, it was in caudate and lenticular nuclei deposition of metal that have been present also in the thalamus, in the peduncles, and in posterior part of the pons. In the meantime, we have followed another family with the same situation, and we try to explain what happened into the metabolic pathway of this situation. So we have evaluated different genes, and we concentrated to a protein that was SLC3810 protein that was mutated in these two brothers, and this has been done by exome sequencing, and this protein that was not known before in the literature is a protein that is able to transport manganese into the body of and outside the patient. We confirmed the mutation in homozygosity in the two patients. We have done also in silico analysis of this protein, and we have done immunohistochemical investigation showing that in the liver and also in fibroblast there is a deleterious effect of this mutation. So the localization of this protein was mainly in the liver, but it was present also in the other organ, and the paper was reported in American Journal of Human Genetics in 2012, in the same moment that also another group with mainly children reported a similar situation, syndrome of hepatic cirrhosis, dystonia, polycythemia, and hypermanganesemia caused by mutation of SLC3810. The group of Tushel from England and GOSP, and our group is on the same issue of the journal. What is this protein? This protein is a transmembranous manganese transporter that is expressed into the liver and the brain, and is involved in the regulation of manganese concentration inside cells, and give some facility for the control of the body manganese level. This protein has been shown by immunoreactivity studies in liver and brain tissue in patients, and it is possible a treatment. So we can eliminate, we can cleave the excess of manganese, and here you see the decrease of, but is much better. You can see if it will work, but it is not working. I don't know why. Okay, but you can see here by this graphic that manganese will go down, and UDPR, the disability evaluation of the patient, will be improved dramatically. And after 3 months of treatments, the patients are normal. They don't need levodopa therapy, and they need only chelation by EDTA once a month, chronically, and from mentation, from tremor, from a neurological point of view, it was a dramatic increase. We try finally to evaluate the apoptosis level in vitro in such patients, and you see that the apoptosis, this is normal cells, and these are the cells of patients. You see that there is a very severe apoptosis in vitro in patient cells. In conclusion, after 100 years from the first publication by Wilson about a very interesting model of metal accumulation into the brain, another model led to describe this clinical situation also in adults with Parkinson disease, but open the knowledge of other proteins that are very important to transport metal across the body and are able to eliminate the excess of manganese that is very toxic for the extrapyramidal system. So it was a very nice model for understanding the physiology of this metal, the manganese, and the pathophysiology has been discovered for copper and other metal on the special vulnerability of this metal on the basal nuclei. This work has been done by a collaboration with a group in Rotterdam, by our group in Siena, and by the first neurologist that sent us the patient in an hospital of the North Italy. Thank you very much.